is the conclusion of the public hearing. And the notes that I got, it is not in the form of an agenda, what I received, is saying that there is a draft Carelon contract with a presentation on opioid abatement strategies. Who is the staff presenting on this?
Yes, this will be Vanessa Gaston who will be taking the lead on this. This is a continuation from the council time agenda on the Carelon contract.
Good afternoon, councilors. I'm Vanessa Gaston. I'm the director for Clark County Community Services. Thank you for quickly putting together some time for us to come back from the July 26th meeting where we discussed the draft contract with Carelon Behavioral Health Administrative Service Organization. We have made those changes based on the recommendations or the changes that you wanted to see. At that meeting, you had asked, could we bring some subject matter experts to come talk to you so you can hear about the need around the increased use of opioids in our community. So I want to thank our presenters because they quickly gathered some information to come talk to you today. So one of the things that we want to do today is so you can hear what the needs are from behavioral health providers, public health, and representatives from the jail services. And I think we have someone from the Sheriff's Department online. And then we're going to, we have a brief PowerPoint presentation that I will go over later so that you can lead you in your discussion about where do you want to see the priorities. We have representatives from Carelon in the audience also so they can hear the dialogue and conversation. And we want to leave today with an understanding of what are your priorities so that we can make sure all of that is incorporated in the contract. So that is the purpose of today. I also want to remind the counselors that you will need to have some discussion at some point and appoint your representatives to the Opioid Abatement Council. We have 3. So the counselors can pick 2, and then public health has asked for a representative to be on there as well. So that would also need to be a decision that needs to also be made so that once the contract is finalized, the first thing they will do is get that opioid abatement council up and going, and then they will start the process for the RFP. So I've asked the behavioral health providers to go first, then I'm going to have public health, and then we'll finish up with representatives in law enforcement, and then we have the PowerPoint up, and then we'll go into the conversation amongst yourselves to talk about the priorities that you like to see. They are here to answer any questions as well. I've asked them to briefly keep their comments concise to under 4 minutes because the bulk of the time we want for you guys to have dialogue and to answer any questions. So I am going to ask Columbia River Mental Health to go first, if you could introduce yourself, and then if there's anyone online, and then we will ask Andrea Pruitt from Public Health to go next.
Good afternoon. My name is Mike DeLay. I am the Program Director for Columbia River Mental Health North Star Opiate Treatment Program, currently operating in that space off of 4th Plain and Andreessen. Been in that position for about 2.5 years and have had the good fortune to work with Dr. Kevin Fisher and our Chief Executive Officer, Victor Jackson, to expand our operations. So when we're talking about the needs of opiate use disordered individuals in our community, you look back to January of 2020, and that's when we started to really see fentanyl enter into the drug supply. And it wasn't hugely obvious. It was kind of popping through in drips and drabs, and then all of a sudden it became a drug of primacy. So in those 2 years, we've seen expansion in our services. So we've gone and increased our client census by about 34%. And that's been driven primarily by the fentanyl use disordered individuals. So 650 to 660 unique individuals on any given month receiving medication through our OTP. And this is fentanyl, carfentanil, fluorofentanyl. There's a variety of fentanyl analogs that are present in the drug system here in Clark County. And it is impacting substance use disordered individuals from a variety of different areas. So not just individuals who have a stated desire to use heroin or painkillers, but also designer benzodiazepines or methamphetamines, all of those substances that are available on the streets have been impacted by the introduction of fentanyl. And as a result, that's driving a much faster search for services. So an individual may have been many years in substance use before they search for a treatment provider using medication-assisted treatment. That timeline is much tighter now. So we're seeing much younger individuals who have been utilizing illicit substances for a much briefer amount of time. And some of the things that we're seeing as being a primary need is an expansion of hours of operation. So we've already expanded our hours from 5:30 to 2 o'clock. But as individuals stabilize on medication and they reintegrate into our communities and become part of our system again, maintaining employment is really challenging if you have to be to the clinic at certain times. And if that's impacting their ability to maintain employment, it's impacting their ability to maintain stability and housing and all those other things that come along with it. So looking at opportunities to expand hours, I think, would be important. Transportation as well. So this is a county-wide issue. It's impacting individuals who are not necessarily easily accessible to public transportation. And those who do come to the clinic with transportation available, it's not reliable. So we're seeing individuals who either can't afford insurance, registration, and car repairs. And it's impacting their ability to come in on a regular basis. So something that we would love to see, or something that we've identified as being really useful, would be a high-capacity transit vehicle dedicated strictly to opiate-dependent individuals being able to access the clinic for the first 90 days, and that transit being driven by an individual with lived experience to provide that engagement and service provision, even in transit, to the supportive service. Another issue that is incredibly impactful to our population is houselessness. So a significant number of individuals seeking treatment for opiate use disorders early in their engagement struggle with unstable or unavailable housing services. And having a really streamlined process or specific housing opportunities for opiate use disordered individuals accessing medication-assisted treatment would go a long way towards supporting them in establishing that initial stability. Words are hard this late in the afternoon, I apologize. Establishing that initial stabilization so that they can get their feet underneath them. And if you look at the studies, it shows fairly clearly that what secures ongoing engagement in a medication-assisted treatment program is early wins. So it's medical engagement, it's clinical engagement, it's peer support engagement, but it's also access to initial positive outcomes fairly quickly after engaging in treatment services. And I think these three targeted ideas would really support those early wins, increase engagement, and also increase the amount of successful stabilizations we'd see early in treatment.
Thank you. And if I would ask, if maybe we could just get through the speakers, and then you guys can ask questions and have some dialogue. Is there any behavioral health providers online, whether it's Lifeline Connections or Community Services Northwest, CMAR?
Yes, this is Andrea Brooks from Lifeline Connections.
Okay, if you could go next, thank you.
Absolutely. Good afternoon. My name is Andrea Brooks. I'm the CEO of Lifeline Connections. Thank you for the opportunity to hear from the behavioral health providers today. At Lifeline, our continuum, in particular withdrawal management and detox, MAT, inpatient, and recovery housing, has really seen an uptick even during these summer months. So typically during the summer, we would see a lull of people wanting to come in and seek treatment. That is not the case this year. And the biggest changes that we've seen are a direct result of fentanyl, and fentanyl now being the drug of choice. With fentanyl, we're seeing a longer withdrawal process. We're also seeing challenges in managing the physical withdrawal symptoms. And some medications are not as effective as we had typically seen in the past with heroin. There is an increase in the severity of complex co-occurring, so both mental health and substance use conditions. We're also seeing an increase in the acuity of medical conditions, diabetes being an example, and xylazine, which is mixed in the fentanyl, is also having some medical impacts on patients. For example, we have more patients coming in with significant sores and wounds that are difficult to treat and require additional medical care, well beyond your standard abscess from using IV drugs. We've also experienced patients testing positive for fentanyl despite their reported use of only using stimulants. In terms of our patients, the needs that we're seeing, so we're seeing increased access to substance use treatment and mental health services, increased access for crisis stabilization. As I mentioned, around the wound care needs, we're seeing an increased need for primary care services to prevent amputations, and also the standard treatments for hypertension, other infectious diseases, and diabetes. As was mentioned, definite need for increased access to housing resources and funding, because without supportive housing, unfortunately, individuals do go back to the street and continue to use. We are seeing individuals have much more complex co-occurring challenges, well beyond what we typically saw in your standard SUD inpatient program. And with the withdrawal for fentanyl longer than other opioids, it is requiring a longer stay. Unfortunately, we've experienced a decrease in the authorization rates from some of our managed care organizations that don't necessarily match fentanyl, what the needs are for individuals. And lastly, I wanted to highlight, we're seeing an increased need for naloxone. Because reversing fentanyl overdoses can typically take 4 to 8 doses versus we typically would use the standard 2 doses in a box. So we're going through one program in particular to highlight as an example is we're going through about 10 boxes that have 2 doses each per week in just one of our programs. And we're also using naloxone more because it reverses the sedative effects of xylazine. Thank you.
Thank you, Andre. Representative from Seymour Community Services Northwest, are you there?
Yes, we're here.
Good
afternoon, counselors. Thank you for your time today. My name is Stephanie Coker. I'm a behavioral health program manager for Seymour Community Health Centers and a certified substance use disorder professional. Seymour operates adult and youth outpatient substance use disorder treatment programs here in Clark County. Our current program has 20 full-time providers that facilitate walk-in assessments, as well as providing outpatient services at our clinic located within the Center for Community Health. We also provide outpatient treatment in 6 local schools, outpatient treatment at open house ministries, and we work closely with the Clark County specialty courts to provide treatment for individuals involved in therapeutic court programs. We also provide assessment services in local hospitals and in the Clark County Jail. Additionally, we provide medication-assisted treatment out of our 4th Plane primary care clinic. These are all programs which I oversee. The information that I'm sharing today on opioid use is based on our knowledge from these services. My understanding is that this group is particularly interested in feedback around 2 questions. Firstly, are you seeing an increase in the population of individuals using for opioid treatment? Yes, we are, particularly in the use of fentanyl, as my colleagues have also shared. Detoxification needs from fentanyl are different and more complicated than detox from former common opioids of abuse like heroin. Heroin is rarely a drug of abuse at all anymore. Most opioid abuse throughout our programs has escalated to exclusively fentanyl use. We've also seen an increased need for Narcan and have distributed over 150 Narcan kits in Clark County over roughly 1.5 years. Opioid overdose continues to be a significant concern across the populations we serve and is not limited to those with opioid use disorders. It's not uncommon for other illicit drugs to be caught with fentanyl, meaning that individuals can be exposed to fentanyl without knowledge of it and without any tolerance for opioids. This increases their risk of overdose significantly. Secondly, what are the needs of the individuals you are seeing specific to those using opioids? The first is rapid access to medication-assisted treatment, meaning that individuals are able to access medications for opioid use disorder the same day that they walk into a clinic pursuing those medications. Motivation for treatment can have a small window, and it's important to engage and intervene with motivated individuals as soon as they express that motivation. Additionally, we see an increased need for access to inpatient treatment, including long-term inpatient services and detoxification services. These detox services must also be equipped to help individuals detox from fentanyl and other complex opioids of abuse. Related to this, it's important to increase bed-to-bed transfers from detox to inpatient treatment. When there's a delay between detox and inpatient, many individuals must return to their communities of use, facing cravings and triggers to relapse before their treatment bed date. This can be very counterproductive to the treatment process. The needs of individuals with opioid use disorders also include stable housing, including assistance with move-in processes and costs, rental assistance, and finding housing that will accept renters with criminal backgrounds. Lastly, in order to be able to recover from their disorders, individuals with opioid use disorders need low barrier access to mental health services, employment, and transportation. Thank you for your time today.
Thank you. Representative from Public Health.
Good afternoon. My name is Andrea Pruitt, and I'm the Community Health Director at Clark County Public Health. In terms of our organizational representation here today, we would like to share with you the Clark County Overdose Dashboard, which is an interactive map that we're going to pull up for your review. Foundational Public Health Services give us the capacity to review and organize different data sets to create pictures to help the community understand trends of overdose use and fatalities over time. So for the purposes of this conversation today, I would like to draw attention to the third tab on the overdose death trends to provide context to what folks have already added in terms of specificity to this dialogue. You'll see side-by-side comparisons and trends over time by drug type, including all opioids, psychostimulants, and also synthetic opioids, specifically fentanyl. So you can see, specific to the data we collect from multiple sources, that individuals in Clark County are experiencing increased rates of death associated with substance use. I think that this information should be used to contextualize decisions made in terms of the allocation of resources and strategies identified in the opioid settlement funds, knowing that we're going to review the three broad categories of available strategies and work through treatment, prevention, and other strategies. Public health understands and tracks trends in populations over time, and we understand the primary drivers associated with these settlement dollars is for use for treatment in individuals who are currently using substances. That said, we want to be a part of the dialogue to consider groups and communities that are currently not using substances and to expand and ensure adequate resources to ensure these populations do not become at risk for using substances, adding to the percentage of the population currently needing or accessing treatment for services. So this data will be updated regularly and includes context on all of the different types of data sources that are used to populate this dashboard. We're also evaluating internal metrics for suspected deaths in partnership with our Office of the Medical Examiner to be able to engage in rapid response activities to ensure we're communicating with our communities regularly to notify them of spikes and surges, trends that we're observing in the distribution of illicit fentanyl in community. So that is something that we would also like you to understand as part of internal data sets that we're evaluating. More than half of the death data that we are currently evaluating involves polysubstance use. We will and are working to collect information on deaths attributed to single substance use. So that's something that we're tracking. Typically, polysubstance use, alcohol use, and another drug also contribute to these rising rates and can be compared side by side across these tabs in this dashboard. So in terms of public health recommendations, we do recommend that a percentage of these allocation dollars be reserved for primary prevention, specifically for youth-engaged strategies to preserve and increase pro-social activities associated with school and building self-efficacy. And also, we understand that there's a critical need to allocate some resources towards leadership and convening a broad spectrum of multidisciplinary partners to ensure stewardship and allocation of resources, knowing that there are many federal, state, local, and private funding streams that comprise the total available amount of resources to do work. We want to ensure that we're supporting our partners and holding managed care organizations responsible for network adequacy and healthcare authorizations, and also ensuring that we're procuring naloxone through all available funding sources. These activities can be conducted in partnership at a larger roundtable as a function of this broader process. Thank you.
Thank you. Representative from the Jail Department.
Good afternoon. My name is Anna Lookingbill, Jail Transition Manager, speaking on behalf of Clark County Jail Services. I think for Clark County Jail, as many people are aware, substance use disorder is part and parcel of the population that we serve. Information from the state of Washington suggests at least 75% of persons incarcerated in Clark County Jail have substance use disorders. And as we've heard from our colleagues, just because you use one thing does not mean that opioids, specifically fentanyl, haven't also been added to the thing that you are using. Also, as often found with incarcerated populations, they tend to be primarily polysubstance users. A person summed this up for me this morning. I had a conversation with a woman who's currently incarcerated in our jail, and she said, "Ma'am, I use all the drugs." I said, "What does that mean?" She said, "I use what I can get because that's how I survive." And so mirroring the comments again from our partners, there's a need for expanded resources in the community, but specifically the jail, because we have such a rich concentration of need. We provide many services around opioid use disorder, yet we know that we can always bring in and provide more. Other things that we have to consider for our population, information from the Division of Behavioral Health and Recovery suggests that people releasing from incarceration are 125 times more likely to overdose within 2 weeks of release. We have a small pilot project we're working on with the Department of Health to make sure naloxone is provided to people who request it. Simply no questions asked, placed in their property so it goes with them. But certainly our, again, information suggests over 3,000 people a year would likely benefit from that. And again, hearing how it's crossing over into other substances, that number increases. This year alone, we've had 7 people in custody overdose on what we assume is fentanyl. It appears to be a fentanyl overdose. Our medical teams responded accordingly. Those are incarcerated individuals who pass through our screening processes. Despite our best efforts, body scanners and other ways that we try to minimize contraband, substances are coming in, and because people are incarcerated and have been using less, it's that much more dangerous and they're that much more likely to die. We have not had a fatality, but that is a very real possibility. Also, we've had officer exposures as part of responding to those overdoses as well. Our staff are okay, but certainly that is an increasing thing that occurs in our building. Things that we're doing, we have an on-site clinically contracted medical provider who is screening for opioid use disorder at time of booking, handling withdrawal symptoms. We're actually a recipient of a grant through the state of Washington through the HCA. It's medications for opioid use disorders in jails, so we're working on getting some pieces in place for that. But again, the need outstrips available resources. We're looking at adding a full-time substance use disorder professional back to our team in the reentry program to provide more in-custody assessments. We have peer support happening. All of our officers and medical staff carry naloxone. But again, I'm sure you're finding a theme. The need of the jail system massively outstrips available resources. Other things that we're considering, this was an idea shared by a community partner that we'd love to learn more about, potentially using the lobby of our jail area as actually a location for a community-based naloxone vending machine. Separately from the focus on placing it in the property of persons releasing from the building, many people from our community come into our space to get information, to check on friends or family, and certainly the more that we can make that available, the safer our community can be. We're excited that these resources may be coming our way. Certainly the jail would love to continue to be part of the process. And again, there's a great quote that comes from a report that we use often where it says, jails are not simply a piece of the opioid epidemic, we're the epicenter. So certainly any support we can provide to persons during their incarceration, we want to do so.
Thank you. Is there a representative from the Sheriff's Department that would like to speak? I see Commander Casper. Do you want to make some comment?
Yeah, I do. I apologize, I'm on the road, so I had to find a spot that had some decent cell service so that I can log in. Good afternoon. So my name's Casey Casberg. I'm a commander with the Sheriff's Office. I've been there for about 25 years now, and currently I'm the investigations commander. So I'm in charge of our major crimes unit, which deals with all of our homicide death investigations, as well as our drug task force, which is at the moment temporarily shut down because of staffing needs. So one of the things that I wanted to start with is that everybody that's gone prior to me has some incredibly good points, and I would highly recommend going back and listening to those again after the conclusion of this meeting to get a good picture of what's going on in the county. But to be clear, most of these cases that are being discussed are not people that are using their grandmother's leftover oxy pills or pharmaceutical grade fentanyl pills. These are counterfeit pills that are being made in home labs, wherever they may be coming from, and they are there is no consistency in between these pills. And as Ms. Lookingbill had said, you know, you get some folks that have been incarcerated for a period of time, and it may be a tolerance issue that they have when they overdose, but it also may just the fact that these are just poorly manufactured, no quality control at all that goes into these pills, and they just may have gotten a batch that is really, really, really hot, and that could affect that too. So what I wanted to inform you guys about today is, if you didn't know, Clark County has one of the oldest multi-jurisdictional drug task forces in the state, and the mission for the drug task force in Clark County is to dismantle or disrupt drug trafficking organizations that distribute these dangerous products within Clark County. We're currently going through a rebranding project to address current issues such as the opioid overdose crisis, but also just to make sure that public officials as well as the public understand that the mission isn't to go and hunt down the corner drug user who's addicted and can't get back on their feet. We're looking at disrupting the supply chain. And what we've learned is that you have to have a holistic approach to the drug problem that's in our community, whether it be the synthetic opioids or the overdose deaths that are occurring on a regular basis. In the past, there's always been two completely separate paths where we saw treatment and prevention on one fork and in law enforcement and correction systems on the other. And those paths have never crossed in the past. And I think now we're starting to see, by working with Clark County Public Health, that those two different directions have to come back together to provide a more effective response. What we would like to do in the future is partner with Clark County Public Health to share information and tools to keep those that do not use illegal drugs from experimenting with them, with the different substance uses. We want to disincentivize people that do use those substances but are subject to becoming addiction affected. And then we want to provide support to the communities that are already drug affected. And by using these disincentive programs, basically the fact that drugs are now illegal again, we can hopefully find reasons to incentivize people to finish the treatment programs that we're able to get into. Another thing that I think is important to remember is that drug trafficking is $1 billion a year industry. Fentanyl just happens to be the current drug of choice for drug affected individuals. They recently passed meaningful legislation in the special session, giving law enforcement some tools to disrupt those drug trafficking organizations that are delivering the synthetic opioids to our community. In recent years, workforce issues in public employment and specifically in law enforcement has contributed to our difficulty in dealing with these public health and safety issues. Vacant positions in our own task force have essentially stopped our work, which has contributed to increases in drug trafficking within Clark County. CCSO recommends that the council consider the prioritization of opioid abatement strategies identified in Part 3 of Exhibit A to support expenditures for first responders, leadership, planning, and coordination to ensure that there's sufficient funding for a high-functioning, well-equipped, multidisciplinary task force that's dedicated to reducing the illicit drug supply in the region. Based on staffing issues, really the fastest way to gain participation from any outside law enforcement agencies is to provide dedicated funding for the work that they do. Coordinated outside agency participation is critical to the success of these multi-jurisdictional units, and without that funding, we may not be able to do that. I think prioritizing funding for the partnership strategy will support our collective ability to work towards those shared goals. Overdose deaths can potentially be eliminated by using that three-prong approach of prevention, risk reduction, and treatment. So sharing information and working together under one roof on these investigations of overdose deaths will move us much closer to disrupting or dismantling the many drug trafficking organizations who are currently poisoning our community. Thank you.
So thank you all. So as you can imagine, a lot of information, a lot of needs, done in a little over 30 minutes. This could easily have taken all day for you to hear all of this information and all the data shown. So I want to quickly go over the PowerPoint and then open it up for you guys to have dialogue and answer any questions. So the next slide. So in Exhibit A, which lists the kind of 3 higher areas. So you have treatment, and these are just some of the categories underneath treatment. Underneath each one are a variety of recommended strategies that kind of defines what that means. So you have the treatment. You heard a lot from the different providers and from the stakeholders talk about the need. 4 areas under that fall up underneath that. The next slide is prevention. And these are the 3 areas. Again, there's a number of strategies underneath each one if you want to know what kind of a little bit more about what those stand for. And then the last one is kind of other areas, as you heard being talked to. And again, there's strategies underneath each one of those. What we need today, we don't need you to go into the specific strategies. Those are just to define what that means. What we want to have a conversation is, where are your priorities? Do you want to, like, if you want to choose treatment, you could put treatment at the top, or you could have a conversation about prevention, or we want to move up some stuff from the last slide up there. We want to have a larger policy conversation about what areas do you want to prioritize. We do not want to be so prescriptive in the sense, because then you kind of, if we don't get proposals, then you're going to kind of hamstrung Carelon. So we want to just have you ask your questions, dialogue, and give us some sense of what are your top priorities so we can make sure that those are captured in the contract. So that is kind of our presentation today. I will hand it over to Chair Bowerman for the dialogue.
Oh my, I'm sitting here thinking, wow, each and every one of these areas is of critical importance. Let's take what the 3 areas are and just highlight them again, because you did a good job of it, but let's be sure that we know what they are, Vanessa. You've got treatment.
Treatment, and in the Exhibit A, they kind of list these categories. So when they say treat opioid use disorder, underneath them are a variety of strategies to define what that means. And so you got the treatment area, broader category. The next area would be prevention. And they have 3 kind of larger categories underneath that. And then they have strategies to define what they mean by that. And then the last area is some other areas. And they have like first responders, leadership, planning, coordination, training, and research. And then they define what that could look like. That doesn't mean that you have to fund what's listed. It's just trying to help you understand what they mean when they put first responders, or they put training. What are they trying to define and think about that?
Very good, thank you. Well, Council, as you look at these 3 areas, which jumps out at you as needing the immediate policy response. And I'd like to then hear from the providers who are here too in response to that, because we all have perspectives on this that are of critical importance. Council, what are your thoughts after hearing this?
Chair, I have a couple of questions, particularly
ahead.
focused for law enforcement. Maybe Deputy Casper can answer my questions. As we know, obviously fentanyl is a large problem in our community, and I'm wondering, since there's an issue with the drug task force being temporarily basically disbanded due to staffing issues, what is the plan for combating drug trafficking and the fentanyl epidemic? And then also I was wondering, with if the drug task force, has it been assisting or leading the overdose deaths in investigations? I know it seems like major crimes has been helping, but wasn't drug trafficking the primary in going after the dealers?
Yeah, you're correct. And yes, and we've only been reassigned to patrol for 2 months now. As our staffing issues are reduced, we are scheduled to get back to work and get back to business. But one of the things that we need desperately is participation from outside agencies. The State Patrol has had a vacant position out there for a significant period of time. A little over a year ago, the Vancouver Police Department pulled their detective and reassigned him to major crimes. So we would really like to gain participation from those two agencies in particular, who have historically been a big part of the local drug task force. But then I'd also like to see Ridgefield, Washougal, some of the outside agencies within the county participate, because they're seeing the same issues that we are. So to answer your question about the overdose deaths, yes. Prior to the reassignment to patrol, we have been looking at the overdose deaths that patrol and major crimes is responding to. And, you know, the controlled substance homicide is a very difficult crime to prosecute. It's difficult for us to investigate because there's not always a lot of cooperation. And if your victim is dead and can't provide any information, then we're stuck with looking at whatever evidence is left over. And so the approach that's taken a lot of times is we gather information on social media, cell phones, cooperative family members that are willing to give information, and then we try and track that backwards to find out where that may have come from. And, you know, it may not necessarily be the person who handed the person those pills that they overdosed on, but more importantly, where did that person get those pills? And the higher up the chain that we can get, the better off we are for everybody. There's article after article in the newspapers in the Northwest about the number of fentanyl pills that are being seized through law enforcement operations, and it's an incredible amount. Does that answer your question? I know it was two parts, but the strategy. So what we're working on is rebranding, right? We're not the drug task force that goes out and sets up stings in our local parks to try and catch these drug affected people that are using. We're not looking for that. We want those folks that are distributing the large quantities in the area and are taking advantage of the people who are facing addiction. So that's what I mean when we're trying to rebrand that, is one, build participation from other agencies, and two, refocus our work to investigate on those overdose deaths, try and prosecute the controlled substance homicides, and disrupt that big supply of pills that are coming in to the area.
Thank you, Casey. It seems like to me that the drug task force, rebranded or whatever it will be when it comes back around again, should be a priority to prevent fentanyl from even coming into our communities so that people don't overdose on it. My other question is and I can't remember, maybe Vanessa can answer this question. Will any of the opioid settlement money go to law enforcement to fund additional deputies to assist with fentanyl?
So the way that would be handled is if you want to prioritize first responders, you would put first responders. We can't determine what would be funded because once the RFP comes out, the proposals need to come in. And this funding right now is just for the unincorporated area of county. So some cities got their own money. If they want to partner with us, we will include them in our contract with Carelon, but they may have their own strategies for their cities. So we're just looking at the unincorporated area. But to answer your question, you would prioritize first responders, and any proposals coming on any first responders would meet that criteria.
Thank you, Vanessa. And then my last question has to do with the dashboard for the county. Does that drill down by age? Can you see people's ages?
Yes, there is a demographic section as well. If you want to tab back, we can look at demographics that are available. And there's also state databases by age and there's a PMP database that provides data by age and sex for prescription drugs. So you can see sex, male, female, age distribution, and race and ethnicity. And then you can also select different sub-drug types, so opioids, heroin, prescription opioids, and then differences in rates by psychostimulant, synthetics. So you see differences. So if you were to observe the differences in utilization rates by prescription opioid versus synthetic opioid, and you look at the rates adjusted for race and ethnicity between the two, you see significant differences, right? And so what is attributing to those changes? That's just one example of how you can look at differences in the data to understand what causal or associated mechanisms drive differences in utilization rates. So, and depending on which area of the dashboard you're looking at, you'll be able to kind of drill down and look at differences. So another one, if you were to go back to the Clark County Snapshot tab, another example, just to highlight what was articulated earlier and the differences in the available drug market between 2019 and 2020. On the left, you see the number of any drug-involved deaths over the past 5 years. If you tab between the differences, beginning with heroin, you'll see the differences. Yep. And so now if you go to synthetic opioids or fentanyl, and you see exactly what our partners are articulating is very much happening in terms of the distribution and supply chain. And to just reiterate what Commander Casberg offered, right? There's no kind of controlled mechanism for the potency of different batches of illicitly manufactured drugs, which contribute to those spikes and surges we discussed that we track very closely to be able to communicate with our partners in the event that there is a batch that goes out that is incredibly potent and increases risk for overdose and death.
I'd like to thank you, Counselor, for calling attention to this area of the first responders. Important. I guess that's under the category of other abatement priorities. We also have treatment and prevention to highlight if those are the policy areas that you feel should be highlighted at this time above others. Your comments, counselors, or for that matter, those of you who are the program deliverance people who know so much about this. And just like Casey, you gave us a tremendous insight there. Are there other thoughts on treatment and prevention?
Madam Chair, I'm
Chair?
happy to speak up.
Yes, go ahead, Councilor Medvigi.
So I want to clearly state one priority. It'll impact different vulnerable groups that are in the face of the community. That priority is this, and we just talked about it at ECHO this morning as well. And it mainly focuses on treatment. And that priority would be simply stated this way. Everyone who's overdosed, who is an addict, must have a readily available bed for detox, medically supervised detox. Readily available. That would impact our homeless populations. When you have all the tremendous effort that's going on now for outreach, and you're making trusting relationships with the homeless people who are addicted, and you finally get them to say, I want help. As soon as you say, great, but it'll be 2 weeks before your intake visit, then you've lost them. If you have someone who's overdosed and they're lucky enough to be in an emergency room, they get detoxed momentarily. Maybe they get to stay for part of their withdrawal, and then they're kicked to the street. You've lost that person. If you have someone in jail who comes in, who's intoxicated, who's an addict, who's committed an offense, you have them involuntarily to provide care. There must be treatment. So to state it plainly, we need available, medically supervised detox bed spaces available without any barrier to insurance, ability to pay. There must be a bed space available, whether it's a homeless person or someone in jail before they get released. That reentry program must have a positive handoff with a continuing program. I'm not going to focus on any particular program like Lifeline, our wellness center, our triage. Those are the services we need. And we need them for every single person. As soon as you have a gap from someone who's willing to get help, you've lost them. So that's where I would like to put all of our resources to solve that singular problem of access for law enforcement who's diverting someone, who's picked up someone off the street. They may have hit them with Narcan. Anyone that's gone through withdrawal once, especially on heroin or fentanyl, they don't want to go through withdrawal again. It's another very powerful inducement to remain addicted. So you cannot have gaps. You have to have transitions. So, and bed space is the answer. And then you double tap on needed available shelter space, bed space for the homeless who are also some of them are addicted. And then you're also targeting that population that's causing the worst problems in our community, those that are committing crimes. So reentry and homeless would be the target audiences. The goal is to have a bed space available for every single person who needs it immediately.
Thank you, Counselor. And now we've heard from two counselors on two of the incredibly important issues of the three. Are there other counselors who wish to comment?
Yes, Chair.
Go ahead, please.
Thank you. So I would like to say I agree with Councilor Medvigi 100%. I cannot say anything different than what was stated there. we absolutely have to have a bed available in order for people to get better. You know, I've heard a lot of discussion about deaths, but I would say that most of us that are in this conversation have lost somebody well before a death ever takes place due to drugs. And it is a nightmare in our community. We've got to solve it. And the other thing that I would say is I think coordination is huge. You know, some of the comments that we heard earlier about coordination between jurisdictions, I'm a little frustrated to hear that they may have their own program because of some imaginary line, and these drugs don't know boundaries, period. So I think that we need to be more functional and have an open dialogue with all different jurisdictions. And the last thing I would say is that we have to be careful not to underfund a lot of programs. To me, it's better to not fund every program and make sure that the programs that we do fund are fully funded so that one little step is not missed. We've got to have more coordination. I don't know how we do this. Something similar, I think HIPAA is probably going to be a problem, but something similar to HMIS where everybody knows where everybody's at, and each individual that goes in for treatment needs to have like a coach or a case manager, somebody that literally makes sure that absolutely nobody leaves treatment without having all the resources, especially housing, stable housing when they leave. Because if we spend all the resources on detox and other services like that, but we don't have a successful plan in place for that person to be successful in their recovery, it's a waste. So I just cannot say enough about how much we need to coordinate, how much we need to know these individuals, know their needs, what are their triggers, how do we get them away from those triggers? Those kinds of things are critical. And then again, I can't say enough about how much I agree with Council Medvigi on that. Our number one focus needs to be that there are beds available for those who need them.
Is there a third perspective from a counselor on the three areas of treatment, prevention, and first responders?
Yes, Chair, I have a few comments.
Okay, go ahead, Counselor.
I guess from what I've heard, and thank you all for your presentation, this is really tough work, and I'm grateful for the work that you do. And it sounds like there's pressing needs really on all fronts. It's difficult to prioritize because I think there are pressing needs on all fronts. I agree with my fellow counselors related to enforcement and treatment, but I am concerned that if you're not addressing prevention, then you will continually be behind the ability to correct this problem. And this funding that's available, I don't know how far this funding can go in terms of prioritization. Maybe it does make sense to throw it all in one area and see what you're doing. But again, you got to be able to stem the tide of the problem that's facing all of us. There'll be additional funds coming down with the settlement later on. So I'd really like to get a sense of really how far this could possibly take us. And, you know, I think all of the counselors can have some opinions about this, but I am really curious. I would like to hear some feedback in terms of priorities from the people who are serving these communities to, you know, you gave us some information of what you're seeing, but if we're to prioritize, I'd appreciate that feedback as well.
Let me just answer your question. So yes, there's this first settlement that will go for 17 years, and then there will be a second settlement. And based on what we read, it's the same, basically you can fund the same thing. So there will be some additional resources coming. Some of those funds end in 7 years, some go out to 15. So it's kind of hit and miss. But when those monies come, they will add additional dollars to the pot that can go out to the community. So I just wanted to answer that question for you as far as what is available right now as far as the dollars. So.
Well, Vanessa, I think we've heard from the counselors at this point with varying priorities for varying reasons, but all good reasons. There's the suggestion that we hear from the providers, and I think that's an excellent suggestion. Would you like to do that, or shall we bring this to conclusion? I don't know your time frame.
So can I just summarize what I thought I heard as priorities?
Yes, please.
Based on people's comments. So I heard first responders. I heard someone caring about prevention. And then I also heard 2 focuses under treatment. So I'm not going to use broad language. So I've said improve access to inpatient treatment and detox with a prioritization of the reentry and homeless populations. And then I also heard improve coordination between systems and improve access to community resources. So I think those are broad enough where a lot of proposals can come up underneath them, so you're not particularly talking about one particular program. And so those are what I heard that can be part of the prioritization. Again, it depends on the proposals that come in for the RFP. So I just want to make sure that I captured what I heard.
I believe that you did, accurately so. Obviously, it can be expanded, but it was, I thought, very accurate. So maybe the next step is to think about appointing the couple of reps to the council.
So maybe Chair Bauer, does anybody want to respond to the 4 areas? I thought you wanted to hear from people in the public. Did you want to hear that or no?
If there are those kinds of comments, let's by all means hear them.
I guess I was interested in just any initial reaction.
Any additional reaction? Looks like none.
I guess they're nodding, so I guess that's a good sign. Great. I would just also like to say a multidisciplinary approach, an ongoing task force that can adaptively manage as new information comes in as we're successful in some areas, because this is going to be going on for some time.
Sorry, which one was that? Is that under?
Are you talking about representatives to the council?
Coordination. I just want to make sure I capture that. The last page.
Madam
Okay,
Chair.
so I got another from underneath leadership and planning, number 3. Okay, got it. Thank you.
Madam Chair, there was one point I had wished to make, but I think some people have touched on it, and perhaps this committee that we're going to be forming will touch on it. This is all primarily going to be about resource management. We need to resource everything we've heard today. We know that, and that's why the hard part is setting priorities, and those may shift over time, or best practices may weigh in. So this committee, I think, will be of utmost importance to the county, because, even the opioid settlement money is going to be coming in for many years in the future. This isn't a short-term burst. So resource management is going to be key to our success and having the greatest impact.
Vanessa, does that council report to you?
The opioid abatement council. So
Yes.
Carelon will create it and staff it, and they will work with them directly. My staff person will not be on the council, but they'll be there present to just listen to the conversation. We will manage the contract with Carelon, not the OAC.
Thank you. So did you wish for us to go ahead and think about appointments to that council today, or take nominations, or how would you like to go? I'd like to know who is interested and who feels that they may have something special to contribute in a particular area. Some may have expertise in a particular area.
Yes, if we could also capture that today, we could walk away ready to go with the language that needs to go in the contract. So I know Public Health wants, someone to, Dr. Melnick probably needs to be part of that conversation about who he would like from Public Health, but we have 2 other seats on that board or that council.
Right. Are there others who would be interested in one of those 2 positions, and tell us why?
Chair?
Yes, please. Is that Councilor Young?
Yes, it is. Thank you.
Go ahead.
I would love to be able to be a part of that. This is something that is really near and dear to me. I also serve on the Mental Health Sales Tax Advisory Board. I'm also on the executive board of National Alliance on Mental Illness, and all of this stuff goes together. I'm very, very involved in homelessness. I would love to take a shot at being on this group and being able to work with people to come up with some good solutions and ideas for the county.
And you have that breadth of experience that you are highlighting. How about others who bring something that you would like to contribute to the group of that will be on the council? Don't be shy.
So, Madam Chair, I'm just so reluctant to volunteer for anything, and I will, and I have to say, I'm a little bit offended by Councilor Marshall's comments about people us having just opinions. You know, this is lived experience for me. And this touches so many families in America, but I spent my whole career dealing in this area, starting in college as an undergraduate. And I have an addicted daughter. I was just administered Narcan several times a couple of weeks ago and brought back to life. So it isn't just for me a matter of opinion. This is lived experience. And to the questions that Michelle was asking, I don't think there's anyone here that believes more in law enforcement than I do. And I was the head lead prosecutor in major narcotics units for years. I mean, that we have lost it in Washington State because of our legislative action, the leverage that we had in our courts and through law enforcement to a great measure. And we can't control that. So I'm all in favor of everything we've been presented today.
Counselor, are you volunteering?
Okay, let me just finish. As to the point of prevention, just to me, it reminds me of just say no. Yeah, that worked real well. I'm sorry, prevention's important, and maybe with our 6-year-olds, but when you start to get into the teenage years, prevention should be amongst our lowest priorities here. We need to deal with the situation that's an emergency right now. I would be happy to volunteer with the one caveat, I'm going to need to shed some other committee at some point. And yes, like Councilor Young, I do have a passion for this and would like to do it, but I'm going to need some relief on some other committee.
And we understand that. Those committees add a great deal in terms of time and commitment.
Chair,
of the heart is one of the things.
If I could just respond, my comment was really not in any way to diminish any lived experience or opinion on anyone on the council, but just to get an affirmation from the people who are on the front line right now.
Okay, thank you for that. Other counselors, do you wish to comment? Is there anyone else who feels that your background would be important for being heard on this council?
Chair Barman, I just actually talked to Councilor Medvigi earlier today in the ECHO meeting. Some people are aware, some people aren't. I worked for Clark County Public Health doing Lifeline Connections contracts, the Share House, all the drug rehabilitation contracts for 3 years. So I do have a wealth of experience. I am not volunteering myself, however, because like the rest of us, we do have a lot of boards and committees But I'm very familiar with the drug rehabilitation contracts for Clark County. So I do have some background and familiarity with that and how those things work for the county. So I just want to put that out there.
Well, I appreciate that and sharing that maybe you did that he may need to shed another committee in the process. The same might be true of you. This is always what it's all about, so that we as counselors can get done as much as we possibly can in a good way. Are there any other comments from council on this? Vanessa, does this a help in going forward?
Yes, it does. And so I just want to say for the representatives, if you need to have time for the third one, we can add that later. But I definitely heard we have a Counselor Young, and there will be a public health representative, and we can get going with that. And then if there's later time that there's somebody can join us a third, let me know, and we can edit that point. So,
Vanessa,
Very
just for
good.
clarification,
Okay.
did you need 2 counselors right now?
it doesn't have to be 2 counselors, but they're the ones who appoint for the 2 positions. And I want to leave Dr. Melnick to kind of choose for public health. So.
Okay, but there could be 2 counselors if they wanted. Okay, so council, do you want just 1 or 2 counselors on this board?
Well, so if Michelle is volunteering, I would definitely defer to her. So I would nominate Glenn Young and Michelle Belkap.
I was not volunteering, Councilor Medved. But if I'm needed, I'll serve. That's fine.
We hear you. And, I think some of this, Vanessa, we can iron out a little bit later as this goes forward, when we know who is going to come forward from public health, et cetera, and make sure that we have the requisite number of individuals. And Kathleen, I think that's more important than just nailing it down today.
Okay,
If you
so
are
right now
okay
we'll
with
just
that.
include Counselor Young, and then come back for further direction. Thanks.
Thank you. And thank you to the presenters. Thank you.
It has been phenomenal listening to you, just phenomenal. And someone suggested that be made available online to others who are interested, and I couldn't agree with that more, because in half an hour you would learn so much about fentanyl and drugs in general in this county. Vanessa, what else? You're the boss.
I think she's done. She's in the audience now.
Okay, in that event, I would suggest that we are all done. I saw Casey driving off into, maybe not the sunset, but driving off. So thank you for your contributions, Deputy. We appreciate that. Everyone who was here, the job that you're doing is phenomenal. And I can't really understand how, with so many competing priorities in the drug scene, that you end up being able to spend the time that we know that you do with fentanyl and then the other drugs individually as well. It is really a phenomenal job that you're doing. Anyone else for the good of the order? Seeing none. This meeting, if this is a work session, is adjourned. Thank you.